Hello, I'm Catherine Riley, a trainee in anaesthesia in Sheffield Children's Hospital. I've been discussing a new guideline that I've written and that we're beginning to implement here in pre-operative assessment with another trainee who's just started here, James Nicholas.
Hello, I'm James. As Catherine says, I'm another anaesthetic trainee here at Sheffield Children's. I was in theatre with one of the other authors of this paper the other day, and she suggested Catherine might be able to give me a bit more of an insight into what they've been doing here in Sheffield.
So our aim is to screen for children's exposure to environmental tobacco smoke. It affects both their anaesthetic and their general health, and we as anaesthetists can help to reduce this exposure and therefore improve both their peri-operative outcomes and their general health, and potentially that of their families too, for the rest of their lives.
It's a pretty bold claim, Catherine. So can we have a look at the evidence? What do you mean by exposure to environmental tobacco smoke?
So this term means inhalation of the products of burnt tobacco. It can be from three main sources: from exhaled smoke from the tip of the burning tobacco product, or from residual tobacco smoke in the environment.
Okay. What relevance does this have to us in anaesthesia?
Well, it affects their perioperative health. The evidence shows us that children who are exposed to environmental tobacco smoke are twice as likely to have an adverse respiratory event, particularly laryngospasm. They also spend longer in the post-anaesthetic care unit, longer until they're discharged, and they're more likely to have an unplanned overnight admission, either to a general ward or a critical care area.
Wow, so lots of perioperative implications then. You mentioned effects on general health too.
Yeah, the Royal College of Physicians have calculated the effect of the exposure to environmental tobacco smoke on a child's general health in the UK. Being exposed to environmental tobacco smoke causes deaths due to sudden infant death syndrome. It increases the risk of bacterial meningitis, of lower respiratory tract infection and asthma and middle ear infections. And children who live with smokers are more likely to become smokers themselves.
Wow, so lots of general health implications too. Bacterial meningitis is a bit of a surprise. Do we know what the mechanism is behind that?
Well, it could be either due to exposure to the environmental tobacco smoke or exposure to smokers, which increases the risk, or it could be both. Firstly, exposure to environmental tobacco smoke reduces the function of cellular immunity, including natural killer cells and neutrophils, and it decreases the secretory immunoglobulin A in the respiratory tract. Also, the components of tobacco smoke on the epithelial cells can enhance the binding of meningococci. Children exposed to environmental tobacco smoke have been shown to have increased risk of both the disease and the carriage of meningococci. Secondly, contact with smokers increases the risk of meningitis, as smokers are more likely to be carriers of meningococcus themselves and therefore expose children as a result of that.
Wow. So, with all of this, what can we actually do about it in anaesthesia? We only usually have a limited time with families before the operation.
That's true, but I don't think we need very long at all. In peri-operative care, we've got this golden opportunity to spread that public health message and deliver the interventions to help families stop smoking. We call it a teachable moment, which is really valuable at a time when families are motivated to make a change, that is, when their child is coming for surgery.
Okay, a teachable moment. So that's a defined thing in peri-operative medicine, is it? Do we know that works?
Yeah, there is some evidence that shows that parents who smoke are twice as likely to have a quit attempt if their child attends for surgery. We know that each quit attempt increases a smoker's chance of abstaining permanently, so just aiming for a quit attempt is valid in itself. For many smokers, it can take 30 or more quit attempts before they're ultimately successful.
Oh, wow. Okay, so we've had a chat about the effects of environmental tobacco smoke. Is there any way that we can screen for exposure?
Well, the easiest way is to ask on the health screening questionnaire, but this has been shown to lack both the sensitivity and the specificity of a valid screening tool.
Yes, I can see the potential for bias with that. Is there anything that we can do that's a bit more objective?
Well, the literature in research, they use Cotinine, which is a metabolite of nicotine. You can measure levels in the plasma, saliva and urine, and they correlate very closely with exposure to environmental tobacco smoke.
Cotinine, okay. It seems a little bit unrealistic to get those samples from every child in a pre-assessment setting. Is there a point of care test that might be a bit more acceptable to patients and their families?
Instead, we could consider measuring exhaled carbon monoxide. The evidence shows us that correlates very well with exposure to environmental tobacco smoke in adolescents, but that evidence is lacking for younger children, perhaps or probably because they find it difficult to perform the vital capacity manoeuvre, which is necessary to generate an adequate end-tidal sample. These carbon monoxide monitors are quick, cheap, portable and easy to use.
Okay, so how might that actually work in practice? Do we use them in any other settings?
Yes, we do. We use them in adult smoking screening programs, and particularly in antenatal care. They've found that the most efficient way is to screen all patients with exhaled carbon monoxide and to follow up any who have a high reading to investigate the cause. This is usually because the patient smokes, but it could be because of environmental tobacco smoke, or it could be because of exhaust fumes or a faulty gas boiler in the house, for example.
Okay. So if we can identify a child as living with a smoker, is there anything we can do about it?
Well, one intervention is to deliver the very brief advice for smoking cessation. This is a quick intervention, and it aims to trigger a quit attempt. It comprises 3 main parts: to ask, advise, and act.
Okay, so we already asked about it in our health questionnaire. So the question asks if anyone in the family smokes, doesn't it?
Yes, that's right. And families can be prepared for this question with posters or leaflets in the clinical environment. We've had some posters made in Sheffield which give information and details of local smoking cessation services. And once we've identified the families who do smoke, we can follow up with advice, such as, did you know that smoking increases the risk of a general anaesthetic for your child? And the benefits of stopping start straight away, and it's never too late to stop.
Okay, so we've talked about asking, and you've given some examples of things we can give as pieces of advice. What about the third part of that then? What about the act part?
Well, we should then act on the response. So if the patient is amenable to that, then we should make a referral to smoking cessation services or give a card with the contact details on, for example.
Okay, and where do you think these interventions should be taking place? Should this just be done in pre-assessment clinic? There's not really any point doing this on the day of surgery, is there? We've kind of missed the boat at that stage.
Well, it's true that if we approach this on the day of surgery, then there's no time to reduce a child's exposure to environmental tobacco smoke preoperatively. But if the child hasn't been through pre-assessment, then I think it's still worth grabbing that opportunity, because by triggering a quit attempt, we might be able to help improve the general health of the child and the family for the future.
So there's a sort of longer term public health aspect to this as well, isn't there?
Yes.
So we could introduce this in outpatients, couldn't we? And on admission to hospital for general admissions, there's no reason we just need to keep this within our sort of peri-op, pre-op setting, is there?
Absolutely, that's right, yes. And it's already been done in the community as well. Health visitors are measuring exhaled and sometimes environmental carbon monoxide to promote their smoke-free homes campaign in Sheffield at the moment.
Okay. So something that's been on the rise in recent years is vaping. Do we know anything about vaping and the effects that passive vaping has?
No, there's nothing in the literature about the effects of passive vaping. The current advice, though, is although vaping isn't risk-free, it's far less harmful than smoking tobacco, and it is recommended as a smoking cessation aid. However, the overall message is strong. It's that quitting all forms of tobacco use remains the single most important thing you can do for your health.
Brilliant. Thanks very much, Catherine. This sounds like something that's got potential for really high impact, both in anaesthetics and in the wider sort of clinical setting. Look forward to reading a bit more about it in paediatric anaesthesia.
Okay, cheers, James. No worries.
Thank you. Bye-bye.
Bye.